Hello, good afternoon, and welcome to this exciting session. Good morning for those who are online, and good evening for some people who are already at 5 o'clock. Can I have our panelists who are in the room to join us upstage? We have Joel and Jessica. Good. Oh, look. How are you doing? Welcome. Yes. So we're going to start with a very exciting session this afternoon, TLC for your VLC, clever ways to improve viral load testing and coverage. Again, a very good afternoon to everybody who is in the room. Good morning to those who are, good morning and good evening for those who are online. My name is Dennis Mali. I am a senior care and support advisor with USAID Southern Africa Bilateral Health Office. We will be discussing this afternoon with a panelist consisting 3 panelists. One is online. I'll be assisted by my colleague from HQ who will introduce himself shortly. Today we're going to be talking about viral load coverage. Just a brief background. The ultimate goal of ART, as we all know, is virological suppression. And that's achievable by every person living with HIV who is on treatment. But you know, over the years, we've had challenges with viral load suppression and viral load coverage. As we started FY19, our viral load coverage was 59%. At the end of FY21, 13 million tests later, our viral load coverage was only 77%. We had a dip in Q3 FY20, majorly due to the COVID-19 pandemic that affected everything that we were doing. So we are still struggling. Our OUs are struggling. Viral load coverage ranges from 33% in Angola to 95% in Rwanda. So we are all trying out to improve viral load coverage so that everybody who is receiving ART receives the clinical monitoring that they deserve. This afternoon, we'll be joined by Joel Kasakaire, who is a medical clinical officer from USAID Local Partner Health Services, Eastern and Central Uganda. This is a project that's implemented by Makerere University Joint Clinical Research Center. Joel has over 4 years experience in providing clinical care for people who are living on HIV on treatment. He has presented 6 abstracts at local and international conferences, including one in Montreal recently at the AIDS 2022. Welcome, Joel. The next panelist will be Jessica Basima. Jessica is a quality improvement advisor, a specialist with USAID Local Partner Health Services, Kigezi and Lango Project, which is also implemented by the Joint Clinical Research Center. You've all seen the beautiful pictures of the JCRC building that was highlighted here yesterday and today by our DAA. Jessica has over 10 years implementing, designing, and evaluating QI projects for PEPFAR programs. She is passionate about data use, including the use of micro-planning and micro-analysis for program improvement. She is having advanced research skills, and she's an awesome person. We are happy to have her today here to present for us on behalf of her project. The third panelist is Blessing. Blessing, the second name is a little bit difficult to say, but Osaze is the name I would say. Blessing is a biomedical laboratory scientist with 18 years experience in lab programs. He is a public health specialist who is also a fellow of the Royal Society for Public Health, England. He is also a survey and vaccination scholar for the WHO. We're excited to have Blessing join us online. I just want to see with our team there if they can give us thumbs up if Blessing is online. Thank you. We'll start off quickly with Joel from the other side. Over to you, Joel.
Okay, thank you. Good morning, good afternoon, and good evening, everyone, both inside here in the room and those who are attending virtually. Joel Kasakaire is my name from Makerere University Joint AIDS Program. Just a simple biography about this project. This project covers 12 districts within East Central Uganda, supporting 126 health facilities in HIV/TB programming. In the building, I traveled with my Chief of Party, Dr. Alneto Moses. I think he can wave for us just shortly. Yes, thank you. So today we are going to share a learning from one of the districts, that is Mayuge district in East Central Uganda, from Mayuge Health Center 4. You all realize Mayuge as a district, we are surrounded by water bodies and the forest reserve. So our economic activity within that district, it is farming and fishing. So Mayuge has many hard-to-reach areas. So most of the clients come from those hard-to-reach areas. So modifying community distribution points to improve value testing coverage and enhance access to HIV services in hard-to-reach areas in the district. So we know the UNAIDS triple 95 strategy, but this time around we are going to concentrate on the 3095. I think everyone in the building know about the 3095, whereby 95 of those clients who are in care should have their viral load suppressed. But however, we can achieve this through viral load testing and adding on other parameters. So we did a deep dive analysis, our data review from Mayuge Health Center 4, and we realized 78% of our clients in care had an up-to-date viral load. So that is really suboptimal. We all know that viral load coverage should be at 100%. So if it is 78, it is really suboptimal. And within this modified CDDP, 35% of the clients from the parent site, that is Mayuge Center 4, are from hard-to-reach islands. That is the forest reserves and the islands. So one of the challenges we realized was about the COVID-19 restrictions. Across the world, COVID-19 affected most of the countries, both in the health sector and the business sector. But this time around, we are in the health sector. So high transport costs, definitely, it is around $13 from the island to the mainland, to and fro. And realize our clients are really not financially stable. So it is quite challenging to get all the services they are eligible for. So we realize also most of these clients had a lot of, maybe most of these clients had mobility challenges, like those in forest reserves. You travel, you move, they walk from their places of residence to the health facility. So amidst all those, alongside all the transaction, the transit, they are passing through forests. So sometimes someone may ignore, like, okay, I will not go and pick drugs. Let me be here and survive. And at the end of the day, our suppression rate is really suboptimal, hence viral load. So some of the interventions, we profiled and mapped clients with an up-to-date viral load tests, and these were clustered based on their locations. We modified the community distribution points. Ideally, we all understand community distribution points. The eligibility criteria for that is we should have stable clients. If I say stable clients, it means someone should have a viral load suppressed. A client should be on ERT more than 6 months. Someone should be in WHO stage 1 and 2. But this time around, the modified came in when we are providing every service. This included both the stable and the non-stable, as we shall go along. So a multidisciplinary team conducted a monthly visit to these modified CDDPs, and a team included a clinician, a counselor, and a laboratory and a record staff. Ideal to have all this to be done, we need to work as a team. we need to work as a team. In the morning, we were talking about, we were discussing, we were learning about data. So we need to have a records person here. And remember, once something is not being documented, it is not done. So at the end of the day, our target is, we should remember our target, 95 suppression rate and 100%, plus all the services provision. So in these modified CDP 75 clients served per CDDP, remember this is a modified one. So we expect a bigger number to be attended to. So CDDP leaders mobilized members to attend these clinics. Ideally, this is being done 2 days prior to the appointment date, in that everyone will come up and come for the investigation, for the assessment, and the other services. So our CDDP leaders were trying to conduct DBS. Ideally, in these hard-to-reach areas, there is no way we can conduct plasma. No, we do DBS because of some transport challenges and all that. So those CDDP leaders were being facilitated for transport DBS samples to the inland hub facility. And it is good. My COP is around. He can even testify. He already signed those ARs to support those transportation of samples from the hard-to-reach areas to the mainland. So a category of clients served in this modified CDDP, as you can see, we have males, females, and also suppression status, the duration on art, those newly on art, and 6 months plus. So after implementing all those interventions, we realized this was kind of a quality improvement approach. Not kind, but it's a quality improvement approach. So after applying those interventions, like you look in Feb, where modified CDDP was being implemented, then monthly visit to the modified CDDPs, realized there was an increment, there was an improvement from 78% viral load coverage to 95% as of June 2022. Being that it is modified, why am I insisting on modification? Because I know other indicators were being impacted by this kind of intervention. For example, viral load coverage for children 0 to 19 years. In January, we were at 72 when we did the data review. But by June, our viral load coverage was 100%. So we have also overall suppression rate increased from 93 to 96. Then viral load suppression for children and adolescents from 73 to 90%. I understand we really have a challenge currently about the children and adolescent suppression rate. But this has really helped us that, okay, fine, the target is provision of services to those clients who are eligible. Get? So our TX, that is our MMD multi-month dispensing, increased from 90% to 95% from the parent side. So modifying service delivery to hard-to-reach areas through a modified approach improves access to timely viral bleeding and other services in care. So we, in our discussion, identifying challenges, PLHIV, affecting access to care and adapting interventions to address them significantly improves access to services for clients in hard-to-reach areas. It's not all about viral load, but all the services such a client is eligible for. So one of the recommendations is profile and map clients missing services to understand barriers to service delivery, then modifying CDDPs, support multidisciplinary service delivery to modify CDDPs. We acknowledge PEPFAR, USAID, Uganda Ministry of Education, Health, Mayuge District's local team, and Makere Joint AIDS Program. And also for any contact, you can contact Dr. Moses Alinaitwe, our Chief of Party. Thank you so much.
Thank you so much. I think our next panelist is online. Our next panelist is Blessing Osaze, who is presenting from Nigeria. Blessing, over to you.
Hi, thank you so much. Good afternoon from Nigeria. My name is Blessing Osaze. Area Bombu. I think that was the difficult one that we had a difficulty pronouncing. We intend to share with you in the next few minutes what our experience has been in terms of trying to address prolonged turnaround time of viral load testing in the Nigeria Medical Institute of Research Laboratory, NIMA, here in Nigeria. As a mechanism, when we came in, USAID Nigeria were at the point of moving the testing platform, the molecular testing platform from NIMA Nigeria to a different facility, owing to the fact that turnaround time was nothing to write home about. There was also poor output in terms of throughput of the mechanism of the platform, the machines itself. And so as a mechanism, when we came in, we felt like we needed to do things differently to get the utmost best out of the facility and the machine in itself. As you are aware, the burden of HIV estimation is about 1.9 million in Nigeria. We have about 1.7 million of them already on ART. And the ultimate goal of putting them on ART is to achieve viral suppression. To achieve viral suppression, they need to have viral load testing done for them. And this needs to be done in such a manner that if the result comes out within turnaround time, for those who are unsuppressed, they could access enhanced EAC, and have their samples taken again to have achieve viral suppression, as it were. So these were our goals. So we felt like we had to do things differently. What were the major barriers we had foresaw when we came in on board? We realized there were a lot of issues with perception from the NIMA management in itself and the old partners. And so we needed to also break that barrier, and there was a need for us to start engagement early. With our funders, USAID, we started the first engagement even before we came on board in January. We had met with them somewhere in Abuja, Nigeria, and to state that there was a need for us to have a holistic approach to getting NIMA to run optimally in achieving its best and functioning at its very highest capacity. And so the first engagement happened, and between January and April 2022, we had scheduled 5 stakeholders engagement meetings, having been led by the USAID Nigeria team led by our ARO, Dr. Donald Oyenka. And then after that, the CEO of Heartland Alliance, Dr. Bartholomew Ochanya, my chief of party, who is there in person. So we continue to engage with them. And after that, we have set out very strategically key performance indicators that we both jointly developed. And we also set out timelines for monitoring these key performance indicators. And there was a need for us to report again on a weekly basis after monitoring daily, create opportunities for improvement as they arose. And that became very, very effective. So what did we achieve? So we saw that before our interventions in terms of having robust stakeholder engagement, having all-inclusive stakeholder engagement, the preceding months, we at NIMA had assayed 45,946 samples were received with an average turnaround time of 21 days. And then between February, when we took over, and July, in 6 months, it has almost doubled from 45,000 to 119,631 samples, which was received within the period. They were not only analyzed, we also brought down the turnaround time from an average 21 days to 10 days, and then steady at 7 days for the last 3 months post intervention. So the standard turnaround time for Nigeria is an average 10 working days, but we've been able to steady at an average of 7 days, and within 5 working days after this abstract was long submitted. So we therefore posit that having participatory engagement with stakeholders at different molecular labs could provide a sustainable means of improving viral load functionality and reducing turnaround time at molecular lab, knowing also that relationship matters in getting desired results from personnel from different laboratories. Thank you very much for listening.
Thank you so much. I think Blessing did mention that the Chief of Party for Heartlands Alliance is here. just in case he drops offline, I think we should be able to take some backup questions from the Chief of Party. Next up will be Jessica Basima.
Yes, good morning, good afternoon, and good evening, colleagues. My name is Jessica Basima from Uganda. I work with Joint Clinical Research Center under the project known as USAID Local Partner Health Services Project, Chigezi and Lango. I'm based in Lango. With me, I came with my project director, Dr. Herbert Samba, and my wave to us, then my OVC colleague, that's Flavia Odochi from Lango. This project supports 10 districts. That's 9 districts and 1 city in Lango sub-region. And there we support 59 ART accredited sites. But together with Chigezi, we have 129 sites. I'm going to present to you the use of quality improvement collaborative approach to reduce the treatment interruption for facilities in Lango. As a country, we have a target of ensuring that at least less than 1% of our clients interrupt treatment. But around sometime last year, as a country, our treatment interruption was high, more than 5%. However, for Lango, we had an IIT of 7%, including sites that are supported by G2G, that is Leader Regional Referral. So the overall treatment interruption for the Lango sub-region was about 7%, which is extremely high, beyond what the national target is. So by interruption in treatment, we mean that PLHIV make 28 days or more after missing an appointment for their drug peak. So, and this is a major barrier to attaining clinical outcomes. We all know that. And Lango sub-region has historically reported high number of client losses. In July to September quarter 2021, about 4,034, that's 7%, of our clients experienced interruptions in treatment, which is extremely high compared to the national target. So as a region, we could not continue like this. So we set out to reduce this. And when we pulled out sites that's supported by G2G, and let's focus on the art sites that are supported by the local partner activity, our IIT was 5.7%, which was still high. So we targeted to reduce it to less than 1% by end of quarter 4 of 2022. So we also had a CIRA, that is cycle of interruption, and return to art, which was also 9.7. These two things are the M&E teams normally monitor them together. So we target to reduce our CIRA also to 2% by the same period of time. And so what did we do? We looked at our sites and focused on sites that had CIRA of 4 and above, and sites that had interruption. So we picked out 30 of our 59 sites that had 80% of our TX CAL, that were contributing big numbers. And we wanted to focus our energies into those ones and see how best do they support us to reduce this. So we availed these sites with the necessary registers to help us to track whatever data we needed to capture. We formed teams right from the project level down to the facility. We had a regional team that was actually reviewing this data on a weekly basis, so sites were able to present to the regional team for guidance. So every week, sites could present. We also had facility-based teams also doing reviews before they share the data for presenting. So we also strengthened our client tracking systems making sure that on a typical day, every client is accounted for. Who has come, who has missed, why have they missed, so we improved our tracking system. We also worked with stakeholders. We brought on very many other stakeholders to strengthen our referral systems. We made sure the necessary directorates, referral networks are open and they are known to everyone to make sure that referrals are done. At the same time, there was also a USAID priority of ensuring that all clients are attached to a community health worker for support. So we made sure that all our clients are attached for a community health worker to increase accountability. Then we had to train all the teams that we brought on board so that we are all on the same page for a common goal. For client tracking, daily line lists were being generated of clients who have missed. They are transferred to the missed appointment register. And since each client was attached to a community health worker was accountable to make sure that they give updates on what is happening to the clients attached to them. We encourage immediate follow-up on that very day, and then home visits for those that they were not able to get. In the same time, USAID also, our team was launching assigning clients their preferred DSD model. So it was a multi-mix of interventions trying to support the same indicator. So at the same time, we rolled out assigning clients to their preferred DSD models through interviewing them and consenting them to the new models they are picking. So we made roles clear to everyone. We got DSD stickers for those who are changing to different models and tag them to their files. Then clear data tracking and reporting. Then daily updates in the EMR. So weekly reviews to fast-track documentation and reports by the WIT teams were also being done. So the other picture is just showing what we did at the inception of the intervention mix, that we had to review all files by site for the other 30 sites to confirm that actually this is an IIT client or it's just a documentation issue before we embarked on the interventions. So over time, over the 4 quarters, our interruptions in treatment have reduced right from 5.7 to 0.8, which is actually below the national target of 1%. Upon implementation, we realized that this intervention mix did not only improve IIT, but we observed some other effects. And we noted that missed appointment trends for our sites also reduced from the 28% to 8% by September 2022. We also improved on receiving services indicator, having attached everyone to a community health worker, so they had to make sure clients receive the services they're eligible for. This indicator also improved from 80% in December to 90% by September. Then we also improved in client attachment. This has been a drive in Uganda across IPs. And by that time, for example, the HIV-exposed infants, only 56% had been attached. But as of September, 90% had been attached. HIV, 86 to 98% currently. And then the adults, currently we are at 99%. Also assigning clients to their preferred DSD models improved from 40% in Jan to 92%. Our SIRA has also reduced from 9.6 as of quarter 1 to 3.3. And generally, our TX-CAL has also improved, which is the goal of the HIV program. And then what have we learned? That collaborative efforts that support healthcare processes, and they improve performance. We also noted that efforts that support the collaborative efforts or collaborative implementation should be strengthened where need be. And then we also observed that improving process for one area leads to improvement in what? In other areas. So as we implement, let's say, embrace mix intervention, because in the long run, other areas also improve. Thank you. We acknowledge PEPFAR, JCRC, and all our partners and the teams we work with. Thank you.
Okay, maybe it's easier for me to go up here. So thank you very much to all three of our presenters this afternoon. I certainly have a couple of questions that we can kick off with, but I do want to see if there are folks in the audience who have questions. Do we still have I think we have a microphone set up over here, so if folks would like to queue, or maybe I can actually send a microphone this way. It looks like we have 4, so I'm going to start with the folks in the area, sorry. Dennis, you going this way? And perhaps if you wouldn't mind coming over this way, the gentleman in the fancy blue suit.
Thank you, presenters, for the wonderful presentation. My name is Anna from Uganda. I work with aid support organization TASO. My question to the last presenter regarding the IIT, it was quite impressive to see the reduction in the interruption in treatment, but my question is about the interrupters in terms of the newly enrolled or the clients who are stable. You presented it at 7% at the start. Was it mainly the stable clients who had been on treatment for long, or the newly enrolled, if you can clarify on that? And then for the second presenter on the labs, that was also quite impressive on how to reduce the turnaround time. My question to you is about the coordination of the hubs, if you can clarify on that, the labs. Was it just the PCR labs, or the coordination between the PCR labs perhaps down to the central lab, how that was done, or it was specific to just the region? And then lastly, still to you, relating to the reduction in the turnaround time, regarding the type of sample that's collected. I know in Uganda we have a challenge with the turnaround time based on the sample type, whether it's plasma or it is dry blood spot. So if you could clarify on that, if that's an issue as well with the implementation that you had in Nigeria. Thank you.
Thank you, Anna. And I guess before we take the next question, I think I'm going to flip it over to Jessica first, and then, or maybe Blessing, since you're online and I have to walk all the way across the stage to get to Jessica, I'll turn the questions for you over to you first.
Thank you very much. Thank you for that question. Actually, our intervention were geared specifically to the regional lab, NIMA mega laboratory, one of the 3 mega labs in Nigeria. And then we basically receive about 90% of plasma. Just now, integrated the plasma separation card as against the dry blood spot. So we moved beyond the dry blood spot. We're doing the plasma separation card now, but the bulk of our samples are plasma samples. Thank you. I hope I've answered it.
Thank you, Anna, for the question. When we looked at our data, actually, the interrupters are clients that have been on treatment for more than 6 months. The interruptions are actually lower in clients that are either 1 to 3 months or 3 to 6 months, but more among clients that have spent 6 months and more on treatment. And it was really sometimes hard to really tell whether these clients are getting drugs elsewhere, but the fact that they did not appear at the clinic and there's no documentation, and they have spent more than 28 days, we counted them as interrupters in treatment. Yeah. But surprisingly, most of them, they tend to have better suppression rates. Yeah.
Thank you. And I can't quite see you behind the...
Yes, thank you so much, Chair, and thank you so much, the presenters. Joel, thank you so much for your presentation on viral load coverage. I am so much interested in the viral load suppression among children and adolescents that did really improve. So I just wanted to understand what were some of the barriers that you did find in relation to the children and adolescents? And what are the critical strategies that you did put across to ensure that you improve viral suppression through this modified CDDP? Because back in the Acholi sub-region, we observed that some of the reasons as to why these children and adolescents are not suppressing is the lack of, people who can provide daily administration of drugs. But how was this done in the modified CDDP? Thank you.
Yeah, let's take one more and then.
Sure. Sorry to overwhelm you, Joel, but I have another question for you. So I'm Jeff Barrow from Jamaica. So two-part question. One was, how much of your improvements do you attribute to the fact that you're using DBS collection rather than plasma? And then really the main part of my question is around your DDD model and expanding it to include the unsuppressed patients. Do you think that those of us who are embarking in a DDD process and we're tentatively, being kind of tentative in the rollout and only including suppressed patients or stable patients to begin with, should be more bold and adventurous and include the unstable from the very beginning? Or do you think that it's really a function of the proportion who are actually unsuppressed, which were low in your circumstance where you didn't see the potential negative effects of expanding to the unsuppressed?
Joel has two hard questions, so I'm going to pass the mic over to him.
Okay, thank you. The first question from my fellow colleague from Uganda, from Acholi region. Yes, true. We realized, one, as I told you first, as a country, and I think as regions, we have issues with suppression rates for the children and adolescents. There are many factors contributing to that, but in this kind of modified CDDP, we have three things which we always do. And one, part of the team which conducted these monthly visits, we have a clinician, we have a counselor, we have an OVC partner. So all those provide the services to these clients, to these children and adolescents. Just in case, if there is, maybe, if the children is not reachable, an OVC partner can come in and guide us the way forward. And hence, we improve the services, then hence contributing to the suppression rate. And another thing, one innovation we have at the facility, that's Migrate Center for, which is not part here, is about the weekend clinic. Weekend clinic really contributed a lot on this. So part of that, weekend clinics were being generated, were being created. And you realize most of these children and adults, especially those going for school, they were missing appointment. So to take you off guard, but this is kind of an information. They were missing appointments. So when we met, we decided to have that weekend clinic, and most of the children and adolescents and their caregivers come. Remember, on a weekend, most of our health workers, we give time to these clients with partnership with the OVC partner. At the end of the day, they get all the services they are eligible for. Then I beg pardon to my fellow colleague from Jamaica.
Yeah, so it was I'll just ask the main one. It was about your DDD model and your choice to expand to the unstable patient. Do you think that for those of us who are embarking for the first time on a DDD exploration, that we should be bold and include the unstable from the very beginning? Or do you think it's because your proportion of unsuppressed was so low to begin with that you didn't experience the negative effects that we expect, which is why we often start with the unstable, with a stable start?
Okay, thank you. This is a modification. It's more like integration. We realize our target is to provide services to this client in hard-to-reach area. Remember, if someone is not being provided a certain service, maybe viral, maybe counseling, maybe viral testing, also contributes to what? To the non-suppression. So if he gets all the services he's eligible for, definitely the suppression rate will increase. So we realized that, okay, fine, we were lagging behind with the viral load coverage. So when we did the deep dive analysis, the data analysis, we realized most of these were from hard-to-reach areas, and the issue was transport. So the health workers had to go to those hard-to-reach areas and provide the services. At the end of the day, as previously mentioned, it is a multidisciplinary team, and we work as a team to provide all the services. Thank you.
All right, so there was a question there, and then there was a question here. I don't know, between the two, who was first?
Thank you so much to the presenters. To Joel again. You did talk about mapping and profiling as one of the key processes that you did. And I'm interested to find out in terms of which ones were the critical cadres that did this activity at facility level. And secondly, did you use a standard tool that can be replicated elsewhere? Please just clarify. Thank you.
Thank you. The cadres have the medical clinic officers. We had the counselors, lab people, lab for bleeding. Then we had also the community health workers. Those are the mobilizers. Because earlier on, previously, before we go to a certain site, because I'm always on ground, before we go to a certain site, we communicate to these CDDP leaders. They mobilize clients 2 days prior to, and then once we go there, we find them when they're already. Remember, these are fishermen, and farmers. There is no way you can go to a certain hard to reach. They can even slaughter you. If they can't slaughter you. So there's no way you can do when you have not made an appointment with them. This is the that's what it means with the hard to reach. Thank you so much.
Did you have a tool?
Pardon?
Did you have a standard tool that you use for the mapping?
Yeah, we have. Okay, thank you.
Yeah. So, thank you very much. My name is Wilson Opudo from Kenya. So I have 2 questions, and my first question is to Blessing. Regarding the TAT, which gap were you trying to solve? Were the challenges at the pre-analytical stage, or was it during the post-analytical stage? Then to Jessica, I think I liked your presentation. I'm very, very passionate about continuous quality improvement. I just wanted to find out, along the care and treatment cascade, despite the fact that you did implement a DSD model, and again, bearing in mind that there's call again to integrate other services. Now we have COVID-19, which is here with us. What was your uptake in terms of TB screening? And also, were there other findings regarding completeness or probably COVID-19 uptake? And this question also goes to Joel. Yeah, COVID-19 uptake and TB screening. Thank you.
Can I take one more from there? Okay, let's take one more.
Thank you very much. Yes, I presented something about receiving services indicator, and that indicator looks at all services across the HIV care cascade. So along the way, as we are implementing to improve IIT, we are also ensuring that the client receives all other services, which includes also the TPT, and then also we are also screening them to ascertain their vaccination status, because that was a national requirement. But during our implementation period, it was a pilot only in about 4 sites in a region where the COVID uptake vaccination uptake was about 80% in the 4 sites. Currently, what we are doing is to scale up to the same to the remaining sites. Then TPT was not our challenge, so it's included in the other services indicator that improved to 90%. So it wasn't a problem on our side. Yeah, what we're tracking, the data we're tracking was for IIT specifically using what we called, we use the Kobo Collect dashboard to monitor and update how we are doing as a region. Over.
Thank you. You talked about COVID-19 uptake with, I think, TB. Ideally, being a modification, more services were being provided. These include the TB screening and also sensitization about the COVID-19. And currently, we are reporting about how many clients who attend clinic who have been vaccinated about COVID-19. Ideally being that this we're targeting about the viral load coverage, but remember also other services. So thank you. I think I've tried to.
Thank you both. Dennis, okay, yes, one last question. Thank you.
Yes, I'm sorry. I'm Catarina from Mozambique. I would like to congratulate all of you for the presentation. To Joel, I would like to know if the costs are sustainable in relation to the patient challenge. And to Blaise, to Jessica, what were the real causes of the patient's absence and the consequent interruptions? If they are guaranteed that the causes will not return? Thank you.
Did you catch that last one? I missed that last one. Could you repeat the last, sorry, could you repeat that second question? I missed that one. I got the first one.
Yes, thank you. The second question is, Joel presented, Jessica.
Yeah.
Jessica. She presented to us the causes of the patient's absence. So I didn't understand the real causes for the interruptions.
Okay.
And I would like to know if after the start, which is the guarantee that the problem is solved.
Okay, thank you, thank you. Okay, so I guess we'll go second and then back to you, oh, I guess you have the mic, Joel. So I will pass to you, Joel, to answer the question. I think this is a very interesting one around sustainability of this model. It clearly is getting results. You're bringing the viral load test to the people and you get very high uptake. How do we make that sustainable, and have there been conversations about how to do that yet?
Okay, I think it is the same question with my colleague who,
exactly.
It's almost the same. And as government, as the Minister of Health and the government of Uganda allocate what we call funds to these health facilities. The funds are being given to these health facilities to implement some of the activities. Yes, for us, the IPs, we are there, but we are just there to sustain, some of these activities. So they allocate funds to departments, maybe the ART clinics, a certain amount. Then we work in collaboration with the IPs. At the end of the day, they are being facilitated. Earlier on, my chief of party is here. You always send the activity requests to make sure that this activity can do what? Can be implemented. At the same time, the facility in charge also allocate some funds. So we work as a team. We join up and we achieve this. In case any IP is not there, the facility team, the facility in charge and the district local government can take over. Thank you.
Thank you for that thoughtful answer. And for our final, yep.
Yeah. Thank you very much, Joel. Just answer your question. It's all about integration that we are trying to promote in our government or district-owned health facilities. So the primary health care funding that comes from the government, we have other funding mechanisms. They are meant to support the facility or government-led programs. So for HIV and TB, we just give additional support. So for viral load monitoring, psychosocial support in those hard-to-reach areas, we are now slowly beginning to integrate with other primary health care activities like immunization outreaches and community dialogue sessions. So there are so many activities that are happening at community level. So integration, even distribution of drugs at community level or through those CDDPs, we try as much as possible to ride on the government-led community outreach programs. Thank you.
Excellent, thank you. And Jessica, over to you for the last word.
Yes, thank you for the question. We had 3 major root causes for our IIT. One of them was in the indicator definition. The teams were not clear who an IIT was. So it was a mixture. You find that even people who have missed an appointment for 7 days were counted as IIT. So we had to build capacity of the teams who an IIT was. The second cause was the weak tracking systems. Clients could miss appointment and we could, no efforts, the efforts were not strong or to make sure that they are followed up and they are accounted for before they become IIT. So what we did was to make sure every client is attached to a community health worker who is accountable for their care. In case they miss, they have to follow up that client before they become an IIT and account for them. Then the third issue was the data management, quality issues in data management, how do we track? So we did also what we call the retention mop-up, had to clean up all our files, file audit, and then we set up a system, a dashboard, where on a weekly basis, each site was able to report who was scheduled, who attended, who missed appointment. Of those who missed, why did they miss? Who are they? Where are they? So that level of accountability, and we started what we called a treatment continuity surge on a weekly basis, just to account for our clients. So that's how we sorted those problems. Thank you.
Great, thank you, Jessica. And I'd like to thank my co-moderator, Dr. Mali. Since he spent his formative years in Uganda, I have to thank Blessing Online because we had to provide some balance. The Ugandans were taking over the panel here. I'd like to also thank Jessica and Joelle for very thoughtful presentations. Thanks for the chatter and dialogue here in the session. And we look forward to seeing you for the next couple of days as well. Thanks, everyone.